Okay, well, thank you. And I want to thank the last speaker. I thought that was absolutely fascinating. And I know that clinical hypnosis is really focused attention, and it really should be taught more in medical schools and other schools because, as we learned, it's such a valuable technique with patients. So what I'm going to do today is I want to talk a little bit about what we missed yesterday. I promised to talk more quickly than yesterday. I had no idea that the translators and interpreters were so efficient here and so fast. And so I spoke very slowly yesterday as the first speaker. I thought I had to speak slowly. But thank you very, very much. You've done a fabulous job. So I promise I will speak more quickly. So yesterday I didn't finish my talk, and I was just getting to the point of moving from more traditional approaches in medicine to the more mystical approaches. And I was thinking about the implication of near-death experiences and how that could change our thinking, including how we approach psychosis. And as I mentioned, oh dear, I'm not sure if I know where the, sorry, I'm going to need a tech person right now because I'm not sure what happened to my control here. Yeah, where do I control it? Sorry. Okay, just, yeah, just, okay, yeah, okay, thanks. Sorry, high tech, the drawer. So, what I did want to talk about was when we look at near-death experiences, the implications are that consciousness is not within the brain, but that consciousness uses the brain and that the brain filters out a lot of sensory input, and that if we didn't have the brain to filter it out, we would be overwhelmed with cosmic information and we wouldn't be able to cope in this world. Well, I also began to think about how do near-death experiences affect our view of psychosis. Now, I'm a psychiatrist. I was taught in the medical model. I was taught that psychotic behavior was a biochemical illness. And in fact, I once went to a church sermon and the minister was talking about possession. The schizophrenic person was possessed. And I was quite horrified because I thought, this poor schizophrenic patient has enough to cope with without being blamed or being perceived as being possessed. And I thought that was rather medieval. Well, my thinking has changed a little bit since then. I was a younger psychiatrist then, and I was quite confident in my views. As the older I get, the more I realize the less we can be sure about in some cases. What changed my thinking was the story of Dr. Ritchie. And Dr. Ritchie was a psychiatrist who wrote the book Order to Return. And when he was in 1943, he collapsed with pneumonia, had a near-death experience. Now, Dr. George Ritchie was the man that influenced Dr. Raymond Moody the most, who wrote the book Life After Life. And because it was the first story that Dr. Moody had heard. And what Dr. Ritchie experienced was collapsing as a young man, and he said, a ward man was carrying a tray, came towards me. Watch where you are going, I said. He acted as though he could neither see nor hear me. He walked right through me. He then found himself, Dr. Ritchie then found himself flying over land and came down to ground near a cafe, later identified in another city, when he saw that city later. And when he was in this near-death experience, he said a second man walked right through him. And then he saw a bright light and heard, stand up, you are in the presence of the Son of God. And he experienced a life review with the Christ. So he was taken by the Christ to various realms, including to a tavern. And he said, I could see civilians having a good time drinking their alcoholic drinks. I could see other beings who were experiencing the same difficulty I had. Their hands went right through the glasses. Then they would stand and watch in great anguish. From time to time, one of the human beings would become totally intoxicated, which caused the electrical field or aura to separate, starting at the head and going to the feet. Sounded like a zipper opening. When this would happen, one of the less dense beings without the aura would try to beat out the other similar beings getting into the human being through the separated electrical field. I gathered that these astral beings had become alcoholics when they were living on the earth. The only way they could enjoy feeling intoxicated again was to enter a human aura. So Dr. Ritchie understood the need to overcome addiction while still alive, or that the addiction would continue after death. So this had a tremendous impact on me. And I thought, well, what are the implications? Was his account cohesive? He was a very dedicated physician, and he just died a couple of years ago, but he lived into his 80s or 90s and was very sound of mind. And was he misled? Or are the biochemical paradigms of illness overly simple? So how is it that human beings can walk through discarnate souls? This suggests that discarnate souls can occupy the same space as human beings. So what kind of energies may be passing by or through us? Does this relate to spiritual warfare? Are we influenced by energies, either angelic or dark? I know in North America there's a whole lot of interest in angelic presences, not so much interest in the dark presences, but who knows what may be passing through us. If discarnate souls can enter intoxicated human beings for the experience of intoxication, perhaps discarnate souls can enter the bodies of human beings who are not in control of their bodies due to either intoxication or psychotic illness and influence horrific acts. So most psychotic schizophrenics don't commit horrific acts. I've had a lot of experience earlier in my career with schizophrenic illness. I ran a day program for young people recovering from acute psychotic episodes and who'd been diagnosed with schizophrenia. And most people with schizophrenia are lovely people that are dealing with a really terrible illness that's it's a terrible struggle for them. And most are very lovely people. But every so often we hear of someone when they're psychotic, and most of them when they're psychotic, by the way, they're still good people, and they're just confused or they may be delusional. But every so often you hear of someone who's psychotic and they commit something absolutely horrific. I knew of a young fellow, and he suddenly decided that his mother was the devil and he had to kill her. And you know, there was a recent one in Canada where someone on a bus beheaded someone else. He cut the passenger's head off. It was horrific. And the person who committed that was schizophrenic, psychotic. So I thought, it's very strange that we have those occasionally. And I wondered how much that what we know from near-death experiences, does this modify our perspective on some of the even core symptoms of schizophrenia? Some of the core symptoms are delusions of that their thoughts are being controlled, or that thoughts are being inserted into their heads or taken out of their head, or that their thoughts are being broadcast. So how much of that actually may be at times related to not necessarily possession, but persuasion or influence by some other discarnate soul? And when we look at symptoms of schizophrenia, auditory hallucinations that are most concerning are those that are internal, critical, or commanding to commit destructive acts. So I'm not denying the validity of biochemical abnormalities, but maybe we need to broaden the paradigm of mental illness. Maybe there's an additional potential for spiritual energies to influence symptoms of an unprotected or vulnerable brain. And I've wondered whether some of these most heinous or horrific acts that have been committed have actually been when the person is psychotic and they're not in control and they're more vulnerable to persuasion by some kind of evil or unpleasant force. So it remains mystical and unknown, and it's not considered by conventional psychiatry. And my colleagues might be shocked to even hear me talking about this in public, because certainly the biochemical model is the prominent one. And I know my own dislike of hearing that maybe there was something other than biochemical process going on. But certainly George Ritchie's account got me thinking about this. And if other entities can enter a vulnerable brain, does this modify our interpretations of multiple personality disorder or reports of demonic possession? How do we interpret these phenomena as psychiatrists? And I wrote, probably carefully and strategically. So that was the end of my talk yesterday, which I would have gotten to if I'd spoken a little more quickly. So now I'm going to, perfect. Okay, so what I wanted to talk about now was the practical application in using stories of near-death experiences. And we talked about NDEs, and I think everybody here is familiar with it after either yesterday, and so I'm not going to review that today. But there are many situations where people can benefit from the stories that other people have the experiences that people have had. Near-death experiences occur in 5% of the population. That's huge, actually. Switzerland was the population 9 million, something like that. So if you think that would be 450,000 people in Switzerland alone who've had near-death experiences. And you think, could it be that common, really? But actually, if you start asking around, you will be astounded how many of your friends, relatives, never mind patients, have had near-death experiences. In fact, I was talking to a family member and was quite surprised that one of my own close family members said, "Oh, I don't need to watch your video about it. I had one myself." And he hadn't told me because he was concerned about it. He thought it was very private. And he didn't want to talk about it. And I've had several friends. So if you start asking, you'll be amazed how many people have had them. But they keep it very quiet because it's such a powerful event, and they don't want it to be diminished or dismissed, and they don't want to look foolish. But that also means that 95% of the population hasn't had a near-death experience. But we can still benefit from the wisdom of those people who have had them. There are many ways that we can use it, and I talk about near-death experiences in my clinical work with patients every week, because we can use it to help people who are afraid of dying. We can use it the stories to help with people who've had near-death experiences and feel nervous about telling anyone about it. We can help with terminally ill patients who are facing death, with suicidal patients, with people who have spiritual dilemmas, people who have a lack of purpose in life, and people with grief. I feel that this wisdom is really underutilized. And you don't have to be a physician or a healthcare professional in some other capacity. You can use this kind of wisdom with friends, with relatives. We all want to help people. And I'm so impressed by the Spiritist community, with the warmth and the dedication of people here to help others. And so maybe I can give you a few suggestions and when you can use these stories. So when we validate these experiences by saying that, you know, we're open to hearing about it, that not all visions or experiences are a sign of a sick brain. Sometimes it's a sign of a very spiritual brain. And when I said that to a patient, as I mentioned yesterday, she said, well, actually, since you're open to hearing about it, I'll tell you, the night before my transplant, I saw an angel who was 10 feet tall, and this angel continues to be a guiding memory for her. And because I was willing to listen to her about it, increase the rapport, she started seeing me again just recently and said she just feels she's able to talk to me about things like a good friend. So I felt that was a real compliment, but I think it was because I was willing to listen to her story in the first place. So when we know about near-death experiences, as I talked about yesterday, what some of the features are, and I'm sure people here are very familiar with them otherwise as well, then we can help people. I want to tell you about one woman who was referred to me by the hematologist. It was a 22-year-old patient, and the referral said anxiety. This was after her transplant for leukemia. And it was thought that she had survivorship issues in coping after her stem cell transplant. So I said, well, why are you anxious? And she said, well, I've been having images about dying. And she worried that these were premonitions that her leukemia was going to recur. And we've just heard about the power of the subconscious in our last talk, wonderful talk, and how that can influence health and illness. And she worried that such negative thinking could lead to a recurrence. So that's why she asked for a psychiatric referral. And so I took her history, and she said that during her hospitalization, that she'd had a cardiac arrest and a code had been called, and this, when she was unconscious, and that she'd been resuscitated, but she had no recall of any of it. So I said, well, tell me about your worries about dying and why you wanted to talk to me about this. And so when she described it, she said, well, actually my worries and thoughts about dying were that I was having a cardiac arrest and I was watching it, and I can tell you which nurse came in and which nurse performed what procedure and what part of the resuscitation. And she said she watched it from the foot of her bed. And I said, well, actually, this doesn't sound like just worries about dying. This sounds like you're having memories of your cardiac arrest. And she had never heard of a near-death experience, and she had no paradigm to explain it. So she just thought these were cooked-up new worries that she was having. But because I knew about near-death experiences, I said, oh, well, this is what it is, and these are the features. You had an out-of-body experience. But she had difficulty with that because she was very proud to be an atheist, and that her identity centered around being an atheist. But I was able to say, well, your experience was valid and legitimate. You'd had a brush with death. It had already happened. I didn't want to discuss parallel universes or anything like that. I said it had happened in the past. She wasn't having a premonition, and these thoughts weren't negative thinking, that she'd survived the code for a reason, and she was still alive for some purpose. And so now we could focus on, move forward from illness worry to determining what her life purpose was. So it was kind of a shift in her thinking. So she had some trouble integrating that because she was so proud of being an atheist. She's still young, and Dr. Erik Erikson has described developmental stages in life, and one of them is consolidating one's identity in the teen years. And I felt that she was kind of stuck at that stage of her identity, that this perception of being an atheist was so strong. But I felt that as she gets older and matures, that she will no longer be stuck in that narrow sense of identity. And then maybe she will be able to consider a broader range of identities. And I suspect that more memories of her near-death experience will surface. And I felt that she was in denial, as I talked a little bit about yesterday. So that's one use of how we can help people with the stories of near-death experiences. Now, the obvious one is for people who are afraid of dying. And awareness of near-death experiences is a way to introduce the topic of death and to reduce the fear of dying in a way that's very intriguing to patients and also hopeful. And what I say to patients, I'm referred patients who are afraid of dying because I work on the leukemia ward and I work in the palliative care ward. And I say, well, have you heard of near-death experiences or the experiences of people who've had cardiac arrests and still survived and been able to talk about it? Because they've come as close as you can get to dying and still have survived to talk about it. And what they tell us is that the actual moment of dying is peaceful to the person inside, regardless of what it might look like to onlookers. And beyond that, it raises the possibility of a spiritual realm. Now, you may choose to accept the spiritual possibilities or not, but we do know that the moment of dying is peaceful. So that's what I say. I emphasize the contrast between external observations and, am I doing?
Just...
What happened? Yeah, but I lost my screen. We're on a different,
Ah, sorry.
Okay, that's good.
That's good like this?
I think so. We're going forward and backwards, so this is, yeah, okay, we're good now. Is that good? Okay. This has been a technological, extreme learning experience for me, I must say, and also quite a challenge with plugs and cords. So what I emphasize with patients is there's a real contrast between what we see on the outside and what the person inside is experiencing. And I say, there's an example of a man who was electrocuted. This is Daniel Brinkley. Some of you may know him from videos and from his book. And he was electrocuted, and it must have looked very violent to an onlooker witnessing what his body experienced. And yet what he described inside was a sound of utter peace, was the feeling of utter peacefulness, sound of chimes, and an orderly quality to the experience. So whatever it might look like on the outside, we know that for the dying person, the experience feels very peaceful. And that's so important. I had a father whose son had died rather traumatically. It was in a children's hospice, but the son had had a sudden heart attack and lunged forward. And the father grabbed him, and the son collapsed. But the father was having elements of post-traumatic stress disorder after that. He kept reliving and reliving that visual image. So I was able to talk to the father, who'd actually been an atheist himself, and we talked about near-death experiences. And I said, I think your son was at peace inside, whatever it looked like on the outside. And I told him the story of Daniel Brinkley and a few others. And he was able to come to terms with it. I also said to that father, you know, it's kind of like a birth into another realm, and in childbirth, women go through the experience of childbirth, but they don't keep reliving that experience over and over. They move on to the next part. And I said, even whatever your son experienced, he would have moved on. And so the combination of moving on and the concept that he probably was at peace really helped that father. And actually, it changed his whole spiritual orientation. He was looking for books and things for me. He got very interested in near-death experiences. There was a woman who was 28 on the leukemia ward, and unfortunately she was told that she had relapsed after her transplant and that she was probably going to only live a few more weeks. So she said, what is it like to die? So they called in the palliative care staff. And the palliative care staff, and I have great regard for them, but I must say that the education there is a bit limited about near-death experiences. So the palliative care doctor came and said, what is it like to die? You want to know what it's like to die? Well, your breathing changes, you start feeling a little colder, you become drowsier, and went on in such a manner, and then left. And I came the next hour, and I said, I hear you saw a palliative care doctor. And she said, yeah, actually I wanted to know what it was like to die, but it sounds pretty awful. I said, did they tell you what it feels like inside to get that close to dying? No, they hadn't. I said, well, it's a good thing that I can talk to you now about this. So we talked about near-death experiences, and that just totally shifted the whole conversation. She was able to see, well, maybe she was going to a next realm. We talked about her uncle who'd gone on ahead, how he was such a joker, how she would have fun seeing him. We talked about with her mother and her young husband. And so the whole tone went from being a kind of macabre kind of view of it, that going to the grave. Instead, we shifted it to a thing of, when she gets to the other side, there's going to be a big celebration. She's going to be there with her uncle, and they would be looking after the family, and the whole mood was different, right until the time that she died, and it helped her husband as well. So we all know of friends and family, relatives that are facing death, and we can be helpful in talking about the potential of celebrating and the arrival on the other side. Now, sometimes people have dreams, and that can also diminish their fear, and I've had several patients who've had dreams of near-death experiences that seem to be equivalent to near-death experiences, and after that they were no longer afraid. So with the terminally ill, we can offer reassurance. And Dr. Christopher Kerr, a hospice physician in New York, has given a TED Talk about dreams and visions of the dying. And he talks that deceased loved ones often come to escort the person and start appearing in dreams or visions before the person dies. And that can be not just when they're in a delirious state, or it's not just the 48 hours before dying, but he said these visions can start even 10 months in advance and occur periodically, or even longer. So I like to ask, have you had dreams or visions of loved ones who've already crossed over? Are they coming to see you? And in fact, when my mother was dying a couple of years ago, I said, Mom, are you seeing anybody? And she couldn't speak at that point, but she could nod, yes. And I said, do you see your parents? No. Do you see your husband? Yeah. And then to check, I said, do you see Mom and your parents? No, again. But you see Dad? Yeah. And she was beaming. And that was a few hours before she died. She was grinning, actually. So I think that we can reinforce the elements of being welcomed by loved ones and of celebrating. Sometimes people can fluctuate a little bit and have some aspects of a near-death experience or visions. A friend of mine was in ICU, and he was delirious, but then he came out of it. And he said, oh, I've been coming in and out of being awake. He said, but you won't believe what's on the other side. I walked down the street from the hospital, and this was he was reliving a dream or a spiritual state, and I crossed the street, knocked on the door, and the door opened, and there's another whole universe beyond that door. You won't believe it, Elaine, he said, and he died the next day. So that was very reassuring to all of us. There was another woman who was dying in a hospice. She was an acquaintance, and I just suddenly felt I had to see her, although I didn't know she was that sick. And I asked her if anyone had been appearing, and she said, well, her brother had been coming in dreams. And so we emphasized that. I talked to her about near-death experiences. I quoted the lyrics from Going Home, spiritual song that says, Mama's waiting for me, Papa's there too. And then she fell into, she was relaxed, and I said to her, well, if I'll go before I do, please welcome me, but if I get there before you do, I'll be sure to welcome you. Otherwise, I'll see you next Saturday. And she was so relaxed after thinking about her brother, and that she calmed right down. She fell asleep, and she never woke up. She actually died a few hours later in her sleep, but I felt that I had helped, and any of us could have done that. It wasn't a major psychiatric intervention. It was just being a human being and reassuring her. Now, I mentioned yesterday that there can be shared death experiences of where a healthy person experiences some of what's involved, some of what the dying person experiences. And William Peters is a therapist in Santa Barbara, California, and he's developed the Shared Crossing Pathway project. And he develops protocols that assist couples where one person is dying. So I took his workshop a couple of times, actually, and basically he emphasizes the strength between the couple, and he has them recalling memories and choosing a memory that's an anchor point. And the concept is that when the person that is dying goes through the life review on the other side, that when they get to that memory, it will trigger a telepathic connection with the person who's alive. Now, those are my words. He didn't use the word telepathic connection, but that was basically how I understood it. And he said that in doing that, there's like something like an 86% chance that the person who survives will have some telepathic experience or an unusual experience. So you can Google him and find more about his program. Now, when I'm working with patients with cancer, they're going through a lot of losses, and sometimes these losses can re-trigger feelings of grief. And and there's anticipatory grief too. Jackie was a born-again Christian who was dying of metastatic cancer. Now, she was very worried that after her death, she would never see her husband in heaven. And because she felt she was saved and he wouldn't be. So she went to her pastor, and he said, well, you're right, he won't be saved. So she went to her doctor, who said, well, I don't have the time to sort out these religious belief systems. So she was referred to psychiatry to see me. And I discussed that many Christians had had near-death experiences, and I talked to her about it. And I suggested that she need to consider thinking outside of the box, and that since she loved her husband, likely God also loved her husband, and that we shouldn't think God has such a small mind as we do, and that perhaps God had some loving solution beyond what our little minds could conjure up about heaven. And this satisfied her, and she died with greater peace of mind about her husband's future, that she would see him. So I also use near-death experiences for the relatives of patients who have died. My patient Paul was dying of a throat cancer, and as he became more ill, we talked about his spiritual beliefs that he would go somewhere after dying. We talked about near-death experiences to give him some greater focus, some ideas, and increased hope. Neither of us knew that would be our last appointment. After his death, 2 weeks later, I met with his sister, and she wanted to know, well, how was he before he died? She wanted to have a connection. I said, well, I don't think he would mind me telling you that that he did think he would go somewhere after his death. And we talked about what I had talked about with him. And so she felt reassured that he'd had some spiritual beliefs. And I said, well, I'd actually showed him a video or watched a video with him about near-death experiences. It's called Life After Life, based by Peter Shockey. It's a documentary from 1992 based on the stories of Raymond Moody's, some of the people that Raymond Moody has written about in his book, Life After Life. And in that video, there is an interview with Raymond Moody and interviews with George Ritchie. And it's a great video. It really captures the feeling of what it's like to float above your body and what it's like to go through the tunnel, because it's done visually that way. So I think it's a great video to recommend for patients. So I'd watched the video with Paul, and I said to his sister, would you like to watch the video? And she did. And it was really interesting because she felt she'd connected with her brother, whom she hadn't seen for a while, but she felt a connection because because she discussed the same things with me that Paul had discussed, and they both focused on a positive concept that he was going to a place of love and a good place. So now I want to talk a little bit about suicide, because this is one of the most important ways we can use near-death experiences. And I've had 2 patients in the past 3 weeks who were suicidal, and this is not in a psychiatric setting. This was in an outpatient clinic with medically ill patients. So my point is that people can have suicidal ideation and in any setting, in medical settings or just in life, in our families. And one of them was a young mother with chronic life-threatening blood condition. She was battle-weary, she had low self-esteem, no previous faith, no life purpose. Her marriage was strained, she was exhausted, and she was having suicidal ideation, and she had 2 little kids, 5 and 7. The other one was a young father, separated, And he told the nurse, I'm going to kill myself if I'm told that my leukemia has relapsed and I'm palliative. He had a 7-year-old daughter. So both of these were devastating situations. And I said, are you having suicidal ideation? And I think it's so important to trust your intuition. And if you have a sense someone may be suicidal, ask and act on it. And one thing I say to patients is, you may feel as if it's hopeless, even though the reality is not hopeless. And that as if sentence is so important in life. You may feel as if things are not going to get better, even though they will. You may feel as if there's no hope for this marriage, even though there is. Could be. So that's a technique that people use with suggestion and hypnosis, and but that's such an important term. And I reminded both of these patients that harming oneself could be a disaster of permanent effects for what is likely a very transient situation or a transient mood. But if you're unsure, call 911 or send the person to the emergency department. Better safe than sorry. And I've said to people, look, I don't want you to go to the hospital to be just at the hospital, but I care about you and I want to make sure you're safe or in a safe place until you're feeling better about things. And so with this fellow, he had this young girl, and both of them had young children. And so when I see suicidal patients, including in the emergency, I say, have you ever heard of near-death experiences? And I said, well, what they tell us is that there is a spiritual realm, that we are known very personally and loved by a spiritual force or higher power, that our lives do matter and have purpose and meaning, and that loving others is the most important. And with this father, I said, your children need to know, or your child needs to know that she's loved and that she needs you. I said, if you were to harm yourself, that could give a message to her that you're not willing to do everything it takes to live as long as you can for her. And when you think about it, if a parent exits earlier than they have to, that can send a message to children that they aren't valued enough. And but I also tell people who are suicidal, and I use this with some judgment, of course, and it's not proselytizing. I use it strategically, and but what I have said is, if you have heard about near-death experiences, there is a story of a young woman in the video, Life After Life, of a woman who shot herself, and she rose out of her body, and the police arrived, and she wanted to say they got something wrong, and but they couldn't hear her, and she said she followed her body along behind the ambulance. But she was met by a being of light, and she was offered a choice to go on or to come back to Earth. And she was said, if you decide to stay over on the other side, you can do that, but you have to know that you will have to go through all of the difficulties you've gone through in this life, all of the pain, and go through further from there. So she said, you're not saving yourself any pain or trouble by exiting early. And she said, I thought about my life, and there'd been a lot of good things, but there'd been a tremendous amount of pain, and I didn't want to have to go through all that pain again. So I decided that I would just stay in the earthly realm and continue this part of the journey. And she said, you're not saving yourself any pain. So I have emphasized that to patients, that, well, there are stories of near-death experiences, but that it's not a good idea to leave this earth early, that we have lessons to learn. And I want to tell you how I used that with one patient. I had an outpatient Lara, and she had chronic suicidal ideation. So I told her about Sandy, this nurse in the LPN in the video who'd shot herself. And I discussed the story with Lara. The following appointment, she stated she'd had some fluctuating suicidal ideation, but that my comments about Sandy had had such an impact that she didn't dare think about acting on those suicidal thoughts. She said, I don't want to go through all of this trouble again. So I feel that there is a role, a strategic role, and using it wisely, that where we can teach about near-death experiences to patients in emergency and inpatient and outpatient settings and in suicide prevention clinics. Other things that I say, I tell them about one mother in one of my groups that I had for women who were dying. It was a group for women with metastatic cancer. And one of the mothers said, every day that I can live longer is one more day. My children have a mother. And I've never forgotten that story. At the same time, there was an advocate for physician-assisted suicide. And I'm not critical of people who choose that route, but that woman who was lobbying for physician-assisted suicide also had a child that was very young. And I thought, what a difference for the children of those two situations. And I thought, I'd rather be the child of the mother who said, every day I can live one day longer, I'm there for my children. So I did say that to this young fellow with leukemia a few weeks ago, that your daughter, Michaela, she needs you. And she needs you to do the best you can. And I said, you can demonstrate being a hero to her. I mean, he was obviously not going to live for a long, long time, but that if he could do the best in the time he had. And actually, that's what happened. He did decide to spend quality time with Michaela. They took a vacation from illness and went to an amusement park or something for one day, and then he was admitted to hospital and palliative care. She took time off school from grade 1 and visited him, and he died in the palliative care unit a few days ago. And I also told him at the time when I first heard that he was suicidal, that every additional day that you live might be just enough for a new drug or cure. And that's not just blowing smoke. I mean, that's just real, that is true. My father was diagnosed with a form of leukemia and was told he had 3 weeks to live. But actually, the diagnosis was incorrect. It was a chronic leukemia. But the year before, or just a few months before, it was a new drug had come on the scene that totally changed the course of his type of leukemia, so that now it was no longer a life-threatening illness. And it was kind of a chronic illness. And he lived for another 11 years. So that story is very true, that every day that you can live a bit longer might just make that bit of difference. I also use antidepressants to increase resilience. Not all the time, but sometimes I'll say this will help you feel a little more resilient in coping with the stresses that you're dealing with. And even in palliative care, antidepressants can work within a few days. It's a myth that takes 3 weeks. So we can also use stories of I'm going to skip over this one story. I'm just concerned a little bit about time. Oh, sorry, sorry, there's more of the challenge, I'm sorry. I'll tell you about one more suicidal patient. I had a patient in the leukemia unit who'd had reactivated TB because he was immune suppressed with the diagnosis. A little bit later, I went to a conference, and a man who was quite psychic came up to me and said, "Someone that you know who's recently had tuberculosis is withholding information from you. It's important that you discuss it with him." So I only knew one person who'd had reactivated TB. So when I got back from the conference, I confronted my patient and I told him what I was told, and from my own intuition asked him directly if he was suicidal. I'd previously asked him in appointments, but he always said he wasn't. So I said, "Well, I was told that you're withholding something from me. Is this true? Are you having thoughts of suicide?" He broke down, told me of his desperation the previous week in the perception of family dynamics and the feeling that his life had no meaning. He is Chinese, and saving face was important to him, and his daughter in her teen years didn't want him to come to a school event or something, and he felt quite rejected, and that was the last straw for him. So I said, "Well, I was told this." He was astounded. He could not believe that I would have gone from Western Canada to Central North America and been met by somebody who came from Florida, who met me there and told me about him specifically. So he said, "I can't believe it, that actually this God loves me so much that he would go to all that trouble to relay the message, and that he knew exactly what I was up to." And so that was so reinforcing to him. He felt his life had some purpose. And a colleague said to me, "Well, actually a life was saved through that interesting encounter." So we can also use near-death experiences for spiritual development for people who don't have a sense of purpose in life. I had a patient, Mary. She was an atheist woman with a narrow life view, with a history of cancer and a multi-generational history of relationship difficulties, and partly due to depression across 3 generations. And I felt she came from a line of prickly porcupines. They were all very prickly and easily incensed. So I tried to help her with medical, psychological, social, spiritual factors. I looked at medical and mood factors, prescribed various antidepressants that I felt might decrease her sensitivity to rejection and criticism. We focused on her childhood issues and helped her to develop some insight into her ways of perceiving herself, the world, and others. I tried to broaden her egocentric perspectives regarding relationship battles with her grown children. I advocated for her at times and tried to bolster her medical and psychological approaches to the physical challenges she had, including shingles pain. I encouraged her to broaden her social network. Spiritually, I tried to encourage her to read and to attend a religious organization that she had once attended for its social advantages. So she was a challenging patient. I suggested she read Life After Life by Raymond Moody. She wasn't convinced. Then I said, "Well, what about reading about children's experiences and Closer to the Light?" She came back and she said, "Well, children haven't been exposed to as much religious propaganda, and they had similar experiences. Maybe there is something to this." Several months later, she was diagnosed in her 80s with metastatic illness, and yet she faced her situation with peacefulness and a new sense of serenity and of hope for her future that was nudged along by her new knowledge of near-death experiences. So I don't know whether the timing for me to introduce the topic was divinely led. I think it was. I had known her for several years, and there was no indication her cancer would return. But after I talked to her about it, she died in hospice a mere 2 to 3 months after the topic was initiated. And in those months, she was much more contented, more philosophical, and less angry than in the previous few years. She now had a greater sense of meaning and perspective for life's journey. So that would be an example of a way that you can use the story. And when I use these stories, it's not proselytizing, it's like, have you heard about these experiences of what people experience when they come so close? I mean, they're kind of interesting to learn about. It's not a religion, it's just an experience that people have had, and we should all learn about these experiences, whether from as healthcare providers or with our family, to help people. And I think we can become more aware of different resources. And I mentioned yesterday some of the resources about reincarnation, that sometimes people think about that if they've been thinking about near-death experiences. And afterlife communication. Grieving relatives are sometimes disappointed that they've not been blessed by communication from their deceased loved ones. But from what I've heard from various individuals, it seems that when people are intensely grief-stricken, they're less likely to perceive the presence of deceased relatives until the intensity of the grief lifts. And that's very helpful to know, for people to know. Because people can sometimes get depressed that they haven't been visited by their loved ones after they've crossed over. Does grief affect the ability to perceive spiritual energy or to shift that perceptual sweet spot of focus? Does it dampen the temporal lobe sensitivity or limbic lobe functioning? I don't know. But I certainly have seen loss of faith with depressed patients, and I think that the feeling of a spiritual deadness can occur too in grief. So it's helpful for people to know that, well, maybe as their grief lifts, they might feel more the presence of their loved one who's moved on, or they might have them appear in dreams. So I'm not sure about time, how much time I have left, or 0? Okay, so I'm just finishing off here. That there are also various offshoots in afterlife communication, and I mentioned briefly yesterday the one started by Alan Botkin, and also similar one by Rochelle Wright, and it uses EMDR techniques, and people feel that they've connected. Now I just want to talk a little bit, this is my final few comments, that I think we need to spread the word about near-death experiences in the medical community. The general population is becoming more open. Certainly the spiritist community is very open and to these concepts, and general population increasingly so. But in academia and in hospitals, it's not taught. It's like a taboo subject, that it's not scientific enough. And yet, these are experiences that people have. It's not a religious thing. It's an experience that we should be teaching about and studying. It's not a regular topic in medical schools. It's not a regular topic even in palliative care training. And it's not a regular topic in psychiatry programs. And it's not a topic in trauma or emergency settings. And it's rarely a topic in medical conferences. It's kind of shocking. I actually had a psychiatrist who was trained in another city, and she was visiting the hospital where I am to do an extra year in psychiatry medical illnesses. And I said, did you have any training in near-death experiences? She didn't know what a near-death experience was. And I thought, well, it's not just my center, this is another center. The palliative care fellows, they're doctors who are working with people who are dying, and I said, do you know what a near-death experience was? And they didn't know, and they hadn't had training. I mean, I've done some seminars. It's actually shocking. And I think, the other night I was on the palliative care ward, and I was seeing the fellow who died, and it was the night before he died, actually. And I saw that a referral had gone through to spiritual care and to help him with his anxiety. And the spiritual care person wrote, well, I did some deep breathing with him, which could help. But really, he was very frightened of dying. And it was almost the sense that it was politically incorrect to discuss religion or spirituality, even in palliative care settings. But beyond that, to even discuss near-death experiences, which aren't a religion, but I think it's that thinking that somehow it's too religious. I don't know. It's not I think there's fear that near-death experiences aren't scientifically fully understood, and that therefore they should be ignored. But it's our patients who are suffering, it's our friends who are suffering because of this silence about the subject. I looked at the library, and for the patients in this palliative care setting, and it was all about grief. You know, goodbye to Lisa, goodbye forever, you know, the last farewell. It was, will I ever learn from my grief? Challenges in grief. It was very upsetting to me. And there wasn't one single book that offered hope for the person who was dying. It may have been consoling to patients, to their relatives, but it was quite distressing to me. So I realized that we really need to be talking more to others about this, certainly in the hospitals. And I thought, if we don't talk about this, it's almost like withholding reassurance. Now, if a person had a pneumonia, we would give them an antibiotic. If you didn't give them the antibiotic, that might be considered medical incompetence. And yet we withhold information about experience, and that information could be so reassuring. And it occurred to me, it's almost a form of medical incompetence if we're withholding that reassurance when we could be reducing suffering. So I became quite rebellious as I looked at that library shelf. So that's my call to arms, that we should be talking about these situations to give hope to people. We need to be teaching students, and these are a couple of recommended videos. The Near-Death Experience, What Medical Professionals Need to Know by Roberta Moore. Life After Life, the video that's very experiential of what people experience. And Afterlife by Paul Perry is another one. Another reason I think healthcare professionals need to be taught is because a lot of them are totally naive about death and about spiritual considerations, and they're left to come to their own perspectives on the issues, often from a spiritual vacuum. And these are the doctors that are going to be treating all of us. And you know, we're going to be in situations, and do we want someone who isn't very well informed about near-death experiences, or a lot of the more subtleties of life and death? Do we want these ones to be making the decisions about DNR orders? And when I say making the decisions, of course the doctors don't do it, it's in discussion with patients, but there is sort of sometimes there's a little bit of a push in a certain direction, one way or the other, depending on which way the physician believes. I don't like to say that, but it's true. And so I think that we need to bring awareness to all kinds of healthcare settings, emergency departments, burn units, ICU, palliative care, naturopathic clinics where patients hope for broader perspectives. And I'd like to finish by saying one woman, as she was approaching death, stated, "Well, I feel a bit anxious, but then I'm always a little bit anxious when I start a new journey." And I think that's a better way to frame the whole, the end of this journey on life in the physical body. Thank you very much for listening.